I'm going to start this session for National Thrombosis Week, which is excitingly entitled VTE Prevention in Hospitalised Psychiatric Patients. And this is actually probably the first time that we've had a whole session devoted to this particular area, which, as you will hear, really needs a bit of help. So I'm delighted to introduce you to our speakers, and then I'm going to hand over to Josie Jenkinson, who's going to lead most of the session. I'm going to be back for questions and answers. So Josie Jenkinson will tell you about how she got into this area. She's a consultant psychiatrist for older people and Deputy Director of Research and Development at Surrey and Borders Partnership NHS Foundation Trust. And she's also Vice Chair for the Faculty of Old Age Psychiatry at the Royal College of Psychiatrists. She's really well qualified. She's got an MSc in Management and Clinical Leadership and has a PhD in Health Services. And her areas of interest outside this include parity of esteem of physical and mental health. Next, we've got Tom York. So Tom was a surgical trainee here at Guy's and St Thomas's, where I'm based, but he has left us to do some work in industry, and here's to say how very different it is. He developed an interest in thromboembolic events in psychiatric patients in his foundation program in Yorkshire. Then we have Dr. Ashma Mohamed. She is a higher specialist registrar in general adult psychiatry at Surrey and Borders Partnership NHS Foundation Trust, and she's involved in a quality improvement program about preventing VTE in inpatients, which you're going to hear about. And lastly, but by no means least, is Dr. Michael Chia, who is a core trainee in psychiatry at the same hospital as Josie and Ashmi, and he's currently involved in the Quality Improvement Project too. So I'm now going to hand over to Josie, and you're in very good hands.
Hello everybody, hi, thanks for such a lovely introduction, and thank you all for taking the time to attend this session this evening. Really exciting. I'm so pleased that we're actually talking about this and got some dedicated time. Bear with me whilst I just share my slides. A second. Okay. Can I check you can see my slides? Perhaps Joe, Beverley, can you tell me? We're good?
Yes.
Yes, fantastic. Okay, so as Beverley said, so I'm Josie. I'm a consultant psychiatrist for older people. I work in a busy liaison psychiatry service in a district general hospital in Surrey. I also did my core training in Surrey many years ago, and that's when I first became interested in this subject. So the format of this session is basically, I'm going to give you more of a national perspective and background to the beginnings of this work, and then we're going to move into more current day projects and hopefully develop some ideas about how some of the audience might develop their own QI projects. So around 11 years ago, during my core training, one of our inpatients died very suddenly, had a really profound effect on me. He, in retrospect, looking back, had multiple risk factors of VTE. He was on 2 antipsychotics, he was dehydrated and immobile, and his post-mortem showed multiple pulmonary emboli. I actually attended his post-mortem, but I was so desperate to find out what had happened. I suspected he might have had PE, and it's a really vivid memory for me actually going to his post-mortem and seeing them, and really inspired me to carry on with this work. I was coming to the end of my core training and had already been thinking about doing a fellowship year, leadership fellowship, which I would highly recommend to any trainees in the audience. And I thought I'd really like to look at this subject as part of my dissertation. So how had this happened? How had we not identified that this poor patient had been at risk and not done anything about it? So I designed a mixed method study, which was a mortality review, an online survey of clinicians, consultant psychiatrists, and some semi-structured interviews with key individuals to try to understand what had happened here. And that was called Critical Analysis of VTE Prophylaxis in Psychiatric The key findings of that study were that around 11% of inpatient deaths across our trust, which is a very big trust, several inpatient units, were attributable to VTE. And just to put that into context, around 25% of inpatient deaths would have been from suicide, so around half. But suicide prevention was receiving huge attention, but we weren't doing anything around VTE. Around 82% of questionnaire respondents thought that psychiatric inpatients were at particular risk of VTE, and 73% thought that NICE guidance should be applicable to psychiatric inpatients. So just as a reminder, back in 2011, when I was doing this work, the NICE guidance around VTE at the moment, I think it was CG 92 or something, I think it was that, and didn't mention psychiatric inpatients at all. There was no mention of them. However, when I interviewed somebody from NICE about the guideline, he confirmed that they were applicable to psychiatric inpatients. They just hadn't felt it necessary to specify that. We found that there were no robust performance measures around VTE prophylaxis for mental health inpatients, which was really in contrast to national sequence for acute trust and what's called the NHSLA standards for acute trust. So the NHSLA is the NHS Litigation Authority. It's like the insurance company, the indemnity provider for NHS organisations. And to be eligible for NHSLA cover, you have to meet certain standards. And there's quite rigid standards around VTE prevention for acute trust, but there's nothing in there for psychiatric trust. That was another powerful lever that wasn't there. The other thing that we found was that the cause of death, people that died for VTE, appeared to be owned by acute trusts, as in it would show up in their mortality data. This is probably because if you think about what happens, somebody has a PE on a psychiatric ward, they usually blue lighted over to an acute trust and may die shortly afterwards, but they're technically an acute trust inpatient, they're not psychiatric inpatient. So there were a couple, such as the person, my patient, who died there and then, but that was actually unusual. It was more common that they would die shortly afterwards in an acute trust. So what happened next? So we made some local recommendations and fed that back to the trust. So that was all around annual mortality reviews, including people who'd recently been discharged or transferred over to acute trusts. Development of a local VTE policy and education training of staff. The Royal College of Psychiatrists were at the time doing a lot of work around parity of esteem and were putting together an occasional paper called Whole Person Care. And we got a section on VTE included in that, which was really great. And the then president of Royal College of Psychiatrists and I wrote to NICE to ask them for a guideline review. We also put together a collaborative study with some other trusts looking at measuring risk in psychiatric inpatients using the Department of Health Risk Assessment tool. So this is to show you the occasional paper that the Royal College of Psychiatrists published. In there were some national recommendations and local recommendations. And so nationally, we spoke about NICE and the NHS Litigation Authority, as well as annual mortality reviews. And locally emphasised the importance of developing VTE prevention policies, which can be audited, establishment of local incident reporting procedures and educational programmes. So thankfully, the NICE guideline came up for review. I applied to be on the panel and managed to get in, which was great. So the review was published 21st March 2018 and now includes a section on interventions for people with psychiatric illness. This is probably the thing that I'm proudest of work-wise in my whole career so far. This took such a long time to do, but it's wonderful. Even now, it gives me a bit of a buzz seeing it. So you can see now that the VTE guideline specifically includes psychiatric inpatients and the importance of assessing their risk as soon as possible after admission and reassessing at the point of consult and review or if their clinical condition changes, and the importance of considering low molecular weight heparin. So just a bit about the cross-sectional study that we did as well. This is all kind of happening concurrently. So it's published in 2019. So I think it was about 6 trusts in total, and we assessed 470 patients using the Department of Health Risk Assessment tool, and found that around a third were at increased risk of VTE, and that patients on older age wards were more likely to be at increased risk, so odds ratio of 2.26. We kind of all knew that intuitively, but it was good to show it. And those people who were at higher risk of VTE, there were some patients where people reported concerns about prescribing prophylaxis. And I think this is probably one of the barriers to implementation of VTE prophylaxis, that psychiatric inpatients have a kind of a group of things that need to be considered, which perhaps you wouldn't pay as much attention to in acute trust inpatients. So things like bleeding risk if people are self-harming, and possibly capacity issues, people who've got cognitive impairments. Just back to the study, so unfortunately only 20, so 4.3% of patients had completed risk assessment. But at the time of collecting the data, the new NICE guideline hadn't come out. That's just that paper there. So in terms of future plans, I would really like to do a freedom of information request to see which mental health trusts have got VTE policies in place now, to see whether NICE guidance has had an effect. I really want to continue to raise awareness nationally, so this is a great opportunity. I'm very thankful to be asked, and continue to support local QI at Surrey and Borders Partnership. So I actually left the trust after my fellowship year and have come back as a consultant. So it's lovely to see Ashma and Michael kind of carrying on doing some of this work. So what I've learned during this process is that change can be slow, really very slow, and stories are important. So the way I got people's attention was by telling the story of our man that died suddenly on the ward. I think national drivers are really important, but change happens at a local level. And one of the things I really regret was I left the trust, and I think I was quite naive. I just kind of gave the recommendations to the trust and assumed that they would be implemented, but they haven't really been, not implemented fully anyway. So I'd say if you're doing anything like this, please pass on the baton. And that's a great segue for me to pass you over to Michael, who's going to start telling you about some more recent local work that's been done at Surrey and Borders. So thank you.
Right, thank you very much, Josie. Just need to try and share my screen. Right, so just going to try and share my screen now. Okay, back to this. Right, can everyone see that? Yes. Right, so thank you very much, Josie, for setting the scene for what Ashma and myself are about to talk about. And so, yeah, this case, which was a near miss, is a bit of an unfortunate deja vu of the case that Josie described happening about 11 years ago, which we'll go into briefly. So this was a near miss of an unexpected PE in a patient with psychotic depression and catatonia. She almost had ECT, which may have been fatal. And it highlighted the importance of VTE risk assessment in all psychiatric inpatients, particularly those at high risk, say catatonia, or those about to undergo ECT. So this was a 53-year-old female. This was her first presentation of psychotic depression, catatonia, poor oral intake, and significant weight loss in the community for months prior to her admission. And she was recommended for emergency ECT as the severity of self-neglect was becoming life-threatening. But thankfully, her first ECT session was actually cancelled due to low potassium levels prior to the ECT, which proved to be very fortunate, as the very next day, she developed sudden onset chest pain, and following further medical investigations, she was found to have bilateral PE. So if you just look to the left here of the sections of the CTPA, you can see where the red arrows and possibly my cursor, her pulmonary system was littered with PEs, and this little section here on the lower left side was actually a pulmonary infarct as a consequence. Thankfully, despite all this, she was actually rather stable. She had no oxygen requirements. She was treated with oral apixaban, and she returned to us just after 3 days. So due to the potential risk of ECT dislodging those clots, treatment thereafter was done by optimizing her medication alone. So she was on venlafaxine, mirtazapine, haloperidol, and it was a slow but successful recovery process, and she was later discharged home with ongoing support from the early intervention and psychosis services. So this near miss really just hammered in how important it is to do VTE risk assessment in patients for psychiatry, particularly those at high risk with catatonia or those about to even undergo ECT. So to cover a topic I'm sure has actually been discussed earlier today, but just to reiterate, A helpful way to try and categorize risk factors for VTE would just be to think about the old medical school principle of Virchow's triad. So stasis of blood flow, hypercoagulability, and endothelial injury. And you can then kind of work out what is what essentially. So antipsychotics, although multifactorial, it's really essentially stasis and hypercoagulability. And these four, restraint, sedation, catatonia, reduced mobility, ultimately stasis. And poor fluid intake is hypercoagulability. So it helps one to work out what someone's risks might be for VTE. And on the topic of ECT and PE, this particular case made us really think about what are the risks with ECT. So we came across this traditional review article that suggested that patients with distal DVT can actually be safely given ECT while continuing oral anticoagulation, be it oral or other ways. However, if they have a proximal DVT or if it's a PE, then ECT shouldn't go ahead and the clot should be fully resolved. So that brings us back to what the standard process is for ECT. So ECT is often in emergency treatment, and the workup usually includes a chest X-ray, but this doesn't tend to always happen because of how urgent it has to be carried out or the state of the patient. And in this case, it may not even have picked up the clot. So a D-dimer as part and parcel of this workup could actually identify any pre-existing PE or DVT, which would then highlight this point that maybe ECT shouldn't go ahead because actually it could risk further embolization. And this lady, for example, may have had a stroke or something worse. So the key reflections that we found from this particular case, this near miss, was that VTE prophylaxis is currently not routine practice for psychiatric inpatients. And maybe that's due to perceived low importance of physical health and mental health patients. And there's a lack of clarity about the psychiatric risk factors for VTE at present, which will be discussed in the coming slides. And VTE risk assessment prior to ECT may actually be a crucial checkpoint, as this often prompts enhanced physical health checks. And this also should prompt a reassessment for VTE and to exclude any pre-existing DVT or PE. On the topic of handover and reassessment of VTE risk factors, we know that risk factors unique to psychiatric patients are not usually mentioned on handover between medicine and surgery. However, as in like when patients are transferred from medicine to inpatient psychiatry, it should actually also prompt a VTE risk assessment. And actually the most important point really is the potential for actual preventable harm, and that the way things are, current practice absolutely needs to change, as there's a risk of potential preventable death if no action is taken, and we may not be so lucky next time. I will now hand over the next section on the development of the QI project to Ashma to speak about, and I'll now stop sharing my screen.
Thank you, Michael. I hope everybody can see and hear me. Yeah, thank you. So Michael has just spoken about the near-miss incident on our ward. Now I'm going to be speaking about what we did following the near-miss. So firstly, we looked at if there was any data available to know how many deaths due to VTE are happening in psychiatric wards or due to psychiatric conditions. But we could not find the statistic. And then we looked at, VTE audits within our trust to check how compliant we are with NICE guidelines. So the 2018 audit clearly showed that we were poorly compliant. And then a recent 2020 audit, which looked at around 3,004 patients across inpatient psychiatric wards in Surrey and Borders, was quite alarming. So 99% of working age patients and 68% of old age patients did not have documented VTE risk assessment. This then led us to set up a QI project. The QI project is very much in its infancy, and through this project, we are aiming to ensure psychiatric patients are given appropriate care within inpatient psychiatric setting, similar to other medical specialties. Secondly, to improve the current process to help clinicians implement VTE risk assessment and to initiate appropriate treatment. So we plan to use a digital solution to ensure a standard uniform process across the trust, in addition to increasing awareness through education. The bigger or the wider goal of this project would be to share our learning and standardize the VTE risk assessment tool across all mental health trusts to avoid differences in evidence-based practice. Finally, to get a consensus to represent psychiatric risk factors in the standard tool, which is by the Department of Health, which will be used universally across all medical specialties. Then after this, we started preparing to do VTE assessment for all of our patients in the ward. So we immediately stumbled on these different forms that we came across. So if you see the first form, VTE form by the Department of Health, it does not represent any of the psychiatric risk factors. Then we looked at the our Surrey and Borders VTE form, and it had catatonia, antipsychotics, etc. on it, representing the psychiatric risk factors. Then we compared it to another local Sussex mental health trust, and they had risk factors such as antidepressants included as well. So there was a bit of confusion over what are the risk factors and how much evidence does each of these risk factors, take on to be considered as risk factors. So I have listed the number of barriers we've come across when trying to carry out this project. So firstly, the differing VTE tools that I just pointed out clearly showed that the practice is variable across mental health trusts, and there is no clear national standard. Therefore, NICE guidelines should review and provide us with a VTE tool that is best suited for psychiatric patients. The risk factors for thrombosis, such as antipsychotics, catatonia, antidepressants, and bleeding factors such as self-harm, and that are very particular to psychiatric patients, may get missed on the standard VTE tool. And by not addressing this, it gives rise to inequality of care provided for patients with mental health problems. Another one is human factors, as this could also be a key barrier that can impact on patient safety. So staff who work in physical health may give less importance to physical health in mental health patients, and the vice versa can happen. So WHO states that there is a 10 to 25-year reduction of life expectancy in people with severe mental disorder, and vast majority of the cause is due to preventable physical health conditions. So VTE could be one such preventable cause that is being given less importance in psychiatric patients. So this is the driver diagram which we've proposed for the QI project we are doing. So we aim to achieve more than 95% of patients on inpatient psychiatric ward to have a VTE assessment on admission by March 2022. So the change ideas are about to bring a sustainable change and to reduce human error. So we are going to do this by having a core digital solution to it. And our primary driver is to increase ability of the staff to conduct VTE risk assessment and prescribe prophylaxis. And secondly, to increase awareness and knowledge. So some of the change ideas include creating a user-friendly, easy access form, standardizing the VTE tool, reviewing the trust policy, and then having robust measurement performance. So like reporting in the MDT agenda and electronic patient report recording, which will prompt the clinicians to complete a VTE assessment. We are also laying heavy emphasis on education of staff, as this is key in addressing the culture to make sure that physical health is held in mind when looking after psychiatric patients. In summary, a standardized VTE tool is taking into account psychiatric patients is fundamental. Exploring further if ECT workup should necessitate VTE reassessment. Collaborating with key stakeholders to redesign a digital solution for sustainable and robust VTE implementation. Finally, to co-produce and co-design solutions with patient and staff to improve patient safety. Thank you very much for listening. Please tweet us at SABP NHS and do get in touch with us if you would like to collaborate. We will also be going online on live QI. And now I'm going to be handing over to Dr. Tom York.
Thank you, Ashma. I'll see if I can share my screen for everyone. Right, can everyone see that okay? I'm going to
Yes.
Perfect. Okay. Well, so first of all, thank you all for having me. I think a lot of what I'm going to talk about is going to reiterate some of those points that have already been made, really. But hopefully that just serves to emphasize how big an issue this is and how valid a discussion point it is. So first of all, a tiny bit about me and why I'm talking to you. So I did my medical training up in Scotland at St Andrews and then Glasgow before doing my foundation training in Yorkshire, starting off at Leeds and some of the satellite hospitals around there. I did my first placement in psychiatry at Leeds York Foundation Trust. Subsequently came down to London. I was an orthopaedic trainee at Imperial and then Guy's and Tommy's, and I've just recently moved into industry, as well as Professor Hunt said earlier. So I think given that, you could probably well question why I'm here talking to you today. I've done 4 months of hematology and 4 months of psychiatry. So compared to the rest of the panel, I am really the least qualified to be speaking to you, but this is nevertheless something I'm really passionate about. I started my work at the Becklin Centre, which you can see in the left side of the screen here. And that's the inpatient and crisis psychiatric units for Leeds and York, some of the surrounding areas. It was a really exciting place to start my work as a doctor. I think it's been touched upon already, along with some of the other foundation doctors rotating into there was a sort of broad perception that I probably wasn't going to be needing to use a lot of my general medical knowledge from university as much as I was some of the psychiatry. I think there is still that kind of lingering lack of parity between the two. We were really quickly proved wrong in that belief. Really similar case to that that Josie mentioned. We had a patient D, who was a 48-year-old chap who'd been on the ward about 2 weeks. He had a primary diagnosis of paranoid schizophrenia with really quite significant persecutory delusions and auditory hallucinations. He was taking lithium and depot aripiprazole for that. Even for the really experienced nursing staff that we had on the ward, he was very challenging to manage. He would transition between sort of extended periods of total non-engagement and lack of movement through to very pronounced agitation and confusion. He was also relatively complex from a sort of medical perspective as well. He had hypertension, asthma, and a chronically infected sort of soft tissue defect over the sort of mid-shaft of his left femur from a parasuicide attempt several years ago. Over the course of about a day, he developed tachycardia and really severe shortness of breath. Being an asthmatic, he was first of all trialed on his PRN salbutamol. No good response to that. And as per the protocols of our trust, he was transferred across to St James's, which was the acute medical unit supporting the trust. He had a CTPA, and just as we've heard already, another case where there was a massive segmental PE. He was started on treatment with low molecular weight heparin. It was tinzaparin, I think, at the trust there. Sadly, he passed away within a couple of hours of that. So the case was really impactful for me personally. I think this was in the first week or so of my practice. It ultimately went to the coroner's court, and it was found that it neither could have been foreseen, nor was it a preventable death. Nevertheless, I think it really served as a moment for some introspection amongst everyone at the trust and to how we were doing with our compliance with that VTE guidance. This was back in 2016-17. I think as Josie's mentioned, that was the CG92 guidance back at the time, which wasn't quite so specific about psychiatric inpatients. In fact, didn't make any mention of it. But nevertheless, it did recommend that everyone have a VTE risk assessment at admission. So we audited how we were doing in terms of compliance with that, and it was a pretty disappointing picture. we found that a little over 2% of our patients admitted over a 2-month period from October to November had actually had a documented VTE risk assessment. It was a paper form, which was a duplicate of that used in the Acute Medical Trust. Nobody really knew where that form was because it was used fairly infrequently. You know, it wasn't copied, it was often out of supply, and for one reason or another, people just weren't using it. Clearly, this was a situation that we needed to improve upon. So risk factors specific to our patient, but more generally, and we've already mentioned a lot of these, catatonia. This was a patient who at times required physical restraint and sedation as well. Use of antipsychotic medications, we've already mentioned that. I think specific to him, clozapine was one of the medications he was taking as well, which I think has some fairly strong evidence now as being at being of an increased risk for VTE in particularly younger patients. And of course, as we've mentioned, all the medical comorbidities. So this was a patient who was hypertensive, has a chronic inflammatory process in the form of an infection as well. So there was an awful lot of things going on for him, which probably could have pointed to him being at a greater risk of a VTE. So what did we do about it? I think we identified really 2 issues going on, and that was a lack of awareness of the protocol that was meant to happen but was happening poorly, but also of the importance of that VTE risk assessment in psychiatric inpatients. Tackled it sort of in 2 ways because of that. The first, really, that lack of awareness. We were lucky in that we received a small amount of funding from the trust to provide some lunch and learn sessions. I'm sure as many of you attending today will know, if you provide free food for a cohort of junior doctors, they will sit and listen to almost anything. But really, this was just a chance for us to get all of those stakeholders. Ashma mentioned that term, and it's used a lot in kind of medical management, but those stakeholders in this process, particularly the junior doctors, but also the wider MDT, the psychiatric nurses, our healthcare assistants, really the whole team involved in sitting down and saying that this was the issue we've had. Clearly, this is something which isn't a trivial point. It's something which is, you know, potentially potentially lethal to some of these patients, and there's something simple we can do to improve upon that. And I think once you relay that point, that perception that it's perhaps not such an important point really disappears pretty quickly. So that was, I think, a fairly easy sell for the cohort we were working with. The second, I think in some ways the harder point we worked on, was dealing with that fairly outdated system of VTE risk assessment that we had. What had been a paper-based prescribing system of the trust had very recently transitioned to an electronic prescribing system, and we used MedChart, which I'm sure if people are working in the NHS, it's used fairly widely. It's certainly, I think, been used at all the trusts I've worked at. We were aware that that system could be used to block prescribing and also create sort of clinical alerts as you were going through the prescribing process. So we talked with our IT department and also the pharmacy team at the Psychiatric Trust, and essentially just worked out on building a really simple rule within the system that blocked all but emergency prescribing. So there was still that kind of safety net that if you needed to prescribe an emergency, you could, but routine prescribing was blocked until a VTE risk assessment was completed and documented on the system. And that pulled in the VTE prescribing protocol, so mechanical or chemical DVT prophylaxis, VTE prophylaxis. I think it was dalteparin we used at the trust at the time. It automatically adjusted that to the weight of the patient on the basis of the demographics that the nursing staff put in. There was a little bit of kind of pushback on this when we started from those kind of education sessions, that this was going to be pretty onerous in terms of a lot of extra admin and what was the payoff going to be. We sat down and we counted the number of clicks that it took to complete this. It was 10 clicks and it was about 40 seconds to complete the admin part of it. So I think we had a really good justification for why it was important. and indeed why doing something like this could be fairly easy and really beneficial to our patients. So then looking at the outcomes of it, so we went back, re-audited our compliance after about 4 months, and we found that compliance had gone up to 100%, so really good. Of course, that compliance is reflecting, hopefully, a real benefit to our patients in terms of mitigating that risk from VTE. I think the reason we saw that success, as has been touched upon already, I guess, was twofold. Firstly, it was about changing, I think, the culture amongst some of the, particularly the foundation doctors that were cycling through psychiatry, that you still had to be very aware of the kind of medical comorbidities, the medical needs of the patient, and how VTE was a particular risk within psychiatric inpatients. But also, frankly, by creating a system where this was mandatory, where it was easier to complete the risk assessment than it was not to complete the risk assessment. And by doing that, we have really good compliance with it. We have, as Josie mentioned, the big problem with a lot of this kind of work is maintaining it after you've done it. It's really easy after someone has a particular kind of meaningful event like this to make a change. It's often a lot harder to sustain it. We've been lucky in having some junior doctors come through after us who've been able to continue those education sessions and re-audit our work afterwards. Compliance has remained really high because of, I think, the systems we've put in place. But also, you know, I'd say to any junior doctors in here, obviously, quality improvement work is something which is central to a lot of the interview and the application process as you get further through. And frankly, selling that side of things as well. This is a simple project that can be done with a really good demonstrable payoff to patients. It makes it quite an attractive thing to, I think, maintain interest in the work. So that's everything I wanted to talk about. I think we're going to move over back to Josie now and some time for question and answers.
Hi, thanks so much, Tom. Yeah, Ashma and Michael, perhaps you could pop your cameras on as well. So I think we've got 53 participants, which is amazing. So that's great. A few questions have come up. Michael, I saw that you addressed a couple of them in the chat box, but I think maybe worth going through anyway. Okay, so just going to have a look through in the Q&A box. So Michael, you answered around, there's a really good question about current risk of death or injury following ECT with respect to buying VTE or coagulation disorders and any data. So you've actually done a literature search, haven't you? And
yeah, and there's very little data, and unsurprisingly, imagine doing an RCT with this. So no, yeah.
So, okay, well, that's a great idea for research study for any researchers out there. There's obviously not enough data there. And timer prior to ECT, is that a useful investigation? That's a really good question as well. I can't answer that question. I'm not particularly up to date on accuracy of D-dimer as a predictor of VTE, but I guess it's something to think about. I don't know if anybody else has got anything to add.
Can I just bump in here? Because we should be using D-dimer to exclude VTE. So a normal D-dimer will exclude VTE, but anyone with an inflammatory problem will have a raised D-dimer. That doesn't mean to say that they have got a VTE. Thank you.
So you could get a lot of false positives if we start doing
it shouldn't be used in that way. You're using it to exclude.
And are there any levels of D-dimer that make it a little bit more sensitive in terms of a test in excluding?
So we have adopted nationally age ranges of D-dimer. So we allow older people to have higher levels of D-dimer. And in pregnancy, D-dimer has got no utility at all. So we shouldn't be using it to diagnose VTE in pregnancy.
Oh, thank you. I knew you'd have something helpful to add. Thank you. All right, so just coming back to the open questions. So sometimes psychiatry patients don't have up-to-date blood tests to decide on appropriate VTE prophylaxis. So we're talking about inpatients, and certainly everywhere I've worked, part of initial clerking and admission process would be to have a bloods panel that's done kind of there and then when the junior doctor clerks in. So I would perhaps argue that that isn't the case for inpatients. Certainly may be the case if you're thinking about patients in the community who perhaps do have an elevated risk as well, but don't have the blood test. But I think that's a whole separate conversation about how we look at VTE prevention in community patients. Another question there's just a statement, I guess, and electronic assessments help with initial assessments, but not great in follow-up review weekly for patients staying longer. I don't know if you've got any thoughts on that, Tom, based on your experience. We don't have so much experience in SBP.
I think we had a routine review every 72 hours where there was a prompt to repeat that assessment.
Okay.
I think, again, the utility of having these electronic prescribing systems, if you're at a hospital that's using it rather than paper-based, is you can essentially create a rule which makes it absolutely obligatory. And whilst that can sound a bit onerous, I think, you know, as soon as people appreciate it's important, it becomes something they're quite willing to do. It's quick to do. Perhaps what I would say is I'm conscious, although we have that prompt, it's fairly easy to click past it, and whether people are actually doing a meaningful reassessment at every 72 hours is perhaps a slightly different issue.
Yeah.
But you certainly can have an electronic assessment which will repeat further down the line.
Yeah. So I think that the prompts are helpful, aren't they? But they're not enough. You've got to look at culture change as well, getting people to understand how important they are. But
can I just say, from the physical side, patients who are physically ill, a prompt is not enough, and you have to have something that's a stop. So some hospitals might have something whereby you cannot prescribe routine drugs to the patient until you've done a VTE risk assessment. And most electronic systems are pretty good these days. So you could, I was thinking about your chronic patients, you could do that once a week. So they had to have VTE reassessment once a week if you've got long.
Yeah, that is part of one of our change ideas as well. So to incorporate it in weekly MDT meetings, so we literally go through that, so we don't miss it out. In if the patient if the clinical condition changes, then we need to reassess.
I think that unfortunately in Surrey Borders we don't have an electronic prescribing system. I do think that that is very, very powerful, because like you say, Beverley, can stop you from being able to do something and then you're forced to complete it. We do have electronic patient records, but there are some pop-ups that you can get in there that kind of block you and make things a bit annoying, but it's quite easy to dismiss them. Whereas with e-prescribing, you can't, you actually have to do it. Our trust has been talking about moving to e-prescribing for a long time, but I don't think there are any imminent plans. But I suspect mental health trusts that already have e-prescribing in place might find that much more useful lever to try to get people to do the right thing. Just coming back to the Q&A box, so yeah, next step should be to do regular VTE assessments in inpatient psychiatry wards. Yeah, absolutely, needs to be educated. Yeah, good project, thank you. Do you think it will be possible to develop a national VTE assessment tool for psychiatry, which all mental health trusts could use? Okay, I just want to say a bit about this. I think this would be the ideal, but I think the problem here is probably a lack of evidence base in terms of the individual psychiatry specific risk factors. I think there's enough there to include antipsychotic use as a risk factor, because there's quite a good evidence base there. I know there's an emerging evidence base on antidepressant use as well now, which probably doesn't have as big an increased risk as antipsychotics, but is a significant risk. But things like catatonia in particular, or severe depression as a comorbidity, I'm not sure if the evidence base is there yet to put it on a national tool. I think there'd be a bit of pushback on that. I don't know what other panelists think.
I have to ask you, how much evidence do you think exists for the national VTE risk assessment?
I don't know. Is it not very much?
Never been properly validated.
Wow.
And it's really just a combination of consensus of what people thought were the risk factors, and we have used it for many years, and it has led to a reduction of national death due to pulmonary embolism. So I wouldn't be so backward in coming forward. I think if you can create something and it's got a logic to it, then you should keep moving and try it out. So you could pilot it. I was listening to your project, you pilot it in your hospital and then you take it out and pilot it in a few other hospitals, and then it becomes national. Ideally, you want data to show that if you use it and you prescribe thromboprophylaxis, you're reducing the VTE rates. But we are talking about quite a low VTE rate, so quite difficult to do. But
yeah,
Josie, you can do this. All of it.
Yeah, I mean, in the past, one of the things I thought would be a fantastic project was using something called CRIS, which is like it's like a mirror of psychiatric electronic patient records that they use in South London and Maudsley, which are the biggest mental health trusts, I think, in the UK, and a couple of other organisations use it as well now. So it's basically a shadow of your electronic patient record, which is completely anonymised, and you can use that to examine vast numbers of patients. And we had thought before that that could be a really useful way to look at VTE incidence in patients and psychiatric patients, and to look at how VTE risk assessment tool implementation was working, because like you say, it's small numbers, so it's quite difficult to show that a local tool is making a difference.
You could actually use national statistic availability, because you could have got hospital episode statistics, haven't you, which tells you if someone's been admitted psychiatrically, and there'll be coding. And then you have to look for the rate of VTE during admission and for the 90 days after admission, because hospital-acquired VTE will occur for up to 90 days post-discharge. So actually that is a possible project for you.
So it would be a lovely project. And so I think I looked into this before, and the data linkage between the mental health minimum data set and mortality databases is not that good, but it is definitely better now. So that, there is a way to do it. That would be make a great research project, wouldn't it?
Yeah.
I think some new questions have come up. Our paper charts require VTE to be re-prescribed every 2 weeks, which helps reassessment. Okay. Yeah, that's quite a good, that's an, if you have to rely on paper drug charts, I guess that's quite a good way of using it. Thank you. Ashma, I was just going back to the previous question. We were talking about different tools and the national tools. It's a really good point. Ashma, that you, in your presentation, you showed 3 different assessment tools, didn't you? Can you just remind us the differences between them?
So the first tool is the which we use in the acute general hospital, which is the Department of Health VTE tool. It doesn't have any of the psychiatric risk factors there. Whereas the one within SABP, within Surrey and Borders, which we use, we have catatonia, poor oral intake, antipsychotics as our risk factors. But whereas the neighboring mental health trust from Sussex, they have included antidepressants as one of their risk factors. So it's quite varied. What are the risk factors that need to be on there? And we could be doing a different practice to another, and where are we with it? So that's kind of led us to answer, come up with that question.
I would have thought that in psychiatry, antidepressant use was widespread, but it increases your risk of VTE, but only a small amount. Whereas I would imagine something like catatonia really does increase the risk. And so you might need to have a scoring system whereby you added things together. If you had catatonia, you might give it a 3 score and make the 3 that you gave thromboprophylaxis, but prescribing antidepressants maybe only would be a 1, and you wouldn't give thromboprophylaxis unless they had other risk factors. Have you thought about doing it that way?
We did have a chat, Josie and I, about risk stratification in case, if because of the evidence that is, it's quite conflicting. Yeah.
I think that's the hard bit where you, like you're saying, Beverley, it pays to just be a bit bold and just do something. But I think the last thing any of us want to do is cause harm by perhaps giving thromboprophylaxis to people that don't necessarily need it and end up with complications from that. So it's weighing that up, isn't it? I think it's probably a bit tricky for junior doctors, particularly early on in their career, to be very confident about saying, right, we should score.
But then we all have to take it together, don't we, Josie?
Exactly.
You and I think we
need to do it together.
Actually work together on this. And I would suggest that after we have finished, we set a time where we all meet up and have a crack at a VTE risk assessment tool for psychiatric patients at a national level, and you pilot it in your hospital.
Well, that sounds like a fantastic idea. Thank you. Yeah, I'm sure we'll all take you up on that. And somebody's put a question in the chat, which I'll just read out. So Audrey Purcell's asked, any evidence for mechanical prophylaxis, e.g. anti-embolism stockings? It's difficult to administer daily subcut injections, refusal by patients, etc. Is there more of a risk of bleeding than VTE risk with SSRIs, SNRIs, antidepressants? Okay, so there's a couple of bits there. So we were talking about this the other day, weren't we, Ashma, when we were talking about antidepressant use being a risk factor for VTE, and how actually it is almost counterintuitive, because we're pre-programmed to think about antidepressants as increasing your bleeding risk, but actually there's evidence base that shows that it increases your thrombosis risk. So I can't quite work out how that can. I'm sure that can both be, though both those things could be true, but I'm not clever enough to work that one out.
I wouldn't worry about it because no one else can. Can I just say that stockings are not recommended in medical patients, and we are starting to remove them from surgical patients. We did a big national trial of 2,000 patients with moderate risk VTE in surgery, and there was no benefit of them having stockings alongside low molecular weight heparin. So NICE are currently reviewing that, and hopefully they will say not to use stockings in many more situations. So stockings are not a good form of thromboprophylaxis.
That's really helpful.
They have side effects.
How about any other forms of mechanical? So if you had catatonia, flotrons, for instance, pneumatic, would that be?
Intermittent pneumatic compression, there's a huge evidence base. It's very effective, but you have to have the system in place. So you have to have a contract to get the little machines that provide the power, and then you have to have the leggings and things to put on. But yes, they do have proven efficacy. Would they be suitable in a catatonic patient?
Yeah, potentially. I mean, there's a capacity issue there, but if there's a good evidence base and they were very much at risk, you'd say it was in their best interest to put on.
Cheaper and easier to use low molecular weight heparin, I think.
Not a ligature risk. Ligature risk is another one which we need to be aware of.
Absolutely, yeah. So that was when stockings were kind of in more general use. When I was looking at this 11 years ago, we identified that as it was a real barrier in psychiatric inpatients because of the ligature risk, that we're so hot on our inpatient environments and making them ligature free. So the idea of giving something to somebody who's very severely unwell that they could then use to strangle themselves is probably not the best idea. So I think that's less of an issue now that we've just kind of completely moving away from the use of stockings. I haven't seen one.
We wouldn't recommend them anyway, so.
Okay, so it's not so much an issue now then anyway. Just having a look at the time, and I think we've talked through questions. Just another point someone's made, the variation in risk factors and tools between neighbouring trusts makes it difficult to decide on the best option forward. I think that's absolutely right. The more national approach would be beneficial. Yeah, I totally agree. I think perhaps progress being slowed by a bit of uncertainty and people not knowing the right direction to go in. So national guidance would be great. And yeah, so I think we have addressed all the questions, unless there's any other questions from within the panel or from anyone else. I think we can start.
I think it's up to me to say thank you very much to all of you, and to say this isn't the last of this subject, that we are going to have to meet afterwards. Before the COVID pandemic, we were talking about meeting up nationally and writing some VTE risk assessment, and then it all got waylaid by what had happened, but we're now in a good place. And I think, Josie, we need to pick up with you and your team and Tom and see if we can pull together some form of VTE risk assessment tool for psychiatric patients that you pilot in your hospital.
Yeah,
yep,
that would be a great idea. We could get the Royal College on board with that as well. That would be great.
Fabulous. And I'm sure also Thrombosis UK can help with a little bit of funding. See Jen nodding there. She's money bags there. Okay, right. So thank you all very much, Michael, Tom, Ashma, Josie.